Now, lastly, we discussed the ACTH, of course, which is the adrenocorticotropic hormone. This is, in fact, the cleavage protein of the proopriomelanocortin. In fact, this is going to be the perfect slide to discuss this. Now, why do we care so much? I mean, the evident and the easiest seen effect of this hormone is going to be from the ACTH. So, while we discuss and we mention it specifically, well, because in normal consequences, in physiological consequences, in conditions, it doesn't matter that much. In the case of pathologicals, you'll see many features, many clinical features of the same patient because of this difference of the other cleave of the other products that are being, of course, produced after cleaving this specific very long peptide. Now, specifically, for example, we're going to talk about just shortly about the melanocyte stimulating hormone and, of course, the lipotropin. Now, lipotropin is in fact not a very well studied protein, and we do not exactly know the full function. There have been different allegations on steroid hormone production and so on, but of course, unfortunately, they are not very well documented. And the point is that we're going to also see the effect and the activity of melanocytes, of melanin producing cells in the skin by the result of the increased amount of proopriomelanocortin produced. So in cases of pathology where we have the increased production or decreased production, it is important to understand that this is going to have multiple features, multiple clinical features, also because of the difference in the other cleaving proteins and peptides that we'll see from this cleavage of this very big molecule. So let's talk a bit about the different parts, anatomically speaking, and of course, as a consequence, there are differences from the anatomical portions to the histological point of view. And in this case, we're going to talk about the pars tuberalis that actually contains mostly gonadotrophs, the pars intermedia that contains mostly right here, that contains mostly basophils, and of course the pars distalis. Pars distalis is actually the biggest area of the anterior hypophysis, and in fact controls up to 75% of the whole adenohypophysis. So let's visualize this structure in the macroscope. By this picture, again, you can see easily the difference between the adenohypophysis and the neurohypophysis just right here, only because of the staining differences already discussed before. So if we zoom in, let's start with the adenohypophysis. Of course, let's zoom in, and we're going to start seeing the two different cells, the two different populations, the chromophils and the chromophobes. Now, in this exact location, we're going to see few chromophobes. Exactly, these cells are not stained. Check the cytoplasm, always the cytoplasm. Now, in these specific cytoplasms, we're not going to find any specific staining or acidophilic or basophilic staining in this case. This is a very typical basophilic staining, and this is a very typical acidophilic staining. Of course, these are vessels. As you can see, this area is highly perfused and highly vascularized because, of course, of the increased necessity of exchange from the bloodstream to the bloodstream and vice versa. And this is actually what you're going to see and be able to distinguish in the macroscopy. You'll not be able to say if the acidophilic cell is in fact a somatotroph or if it's a lactotroph. It's not enough. You don't have enough data. And in the case of the basophils, you're not going to be able to tell which of them specifically is. So this is just what you should end up with. It's just simply the questions, the clinical, the microscopic questions will not be a lot because you don't have a lot to answer because of the few information that you have in your hands. Now, if we actually go to the posterior pituitary, we should see exactly, again, the difference in the staining methods importantly, and we're going to find these two different components. Now, these are areas that are filled with axons and herring bodies. Now, if we zoom in this area, this specific location, we're going to find, again, capillaries specifically, and we're going to see all of these cells are, in fact, the pituitary. They're nuclei, and these are specifically glial cells. And let me try to find a specific herring body that will actually help you. For example, there we go. These are herring bodies. These are the axonal dilations that we can actually find in the section of the pituitary glands in the neurohypophysis. Let's actually see if there is some bigger one in this case. This is a big one, I suppose, but it's not. I don't like to stain this specific one. This is a much better section right here that we can actually find the eosinophilic big dilation of the axons in this case, and similar, of course, structures to these will always indicate the herring bodies, or also neurosensory bodies. So let's talk about let's move on and talk about the adrenal glands. Now, the adrenal glands are, of course, as the name suggests, the glands that are exactly above the kidney. And here, just by looking at the section of this, you can understand that there are three different areas. Of course, there's the capsule, as always, the cortex, and the medulla. Again, cortex and capsule. So let's talk a bit about the differences between the cortex and the medulla, the functional and morphological ones. So in the cortex, we're going to find three different zones. The Zonula Glomerulosa, which in fact contains and produces mineralocorticoids. What does it mean, mineralocorticoid? Of course, this is the aldosterone. Now, the mineralocorticoid exactly and specifically means the aldosterone. Aldosterone, as we discussed already in the urinary system, is a very big part of the renin-angiotensin aldosterone system, and as a consequence, the effect of this hormone is that it actually reabsorbs sodium, it reabsorbs partly potassium, and as a consequence, it reabsorbs also water. Now, we already discussed the mechanism shortly, of course. Again, we'll discuss it just right now, just a bit. This is again in the case of a loss of volume, or in case of we're gonna find the loss of osmolarity in the blood. We're gonna have the need to regain and to re-establish the specific balance of the osmotic pressure in the blood. So whenever we have loss of volume, whenever we lose blood, the human body will in fact start to a whole coping and compensatory mechanism to regain the volume. And in this, of course, case, in the production of aldosterone, this is one of the ways that reabsorb sodium, potassium, and as a consequence water. So we increase the volume of the blood inside the cardiovascular system. And we already saw that the angiotensin 2 exerts, of course, the biological effect of vasoconstriction. So we try to regain the volume that we lost, and by, of course, with this volume, we also, by reducing the lumen of the capillaries, of the vessels, we increase the blood pressure. So this is exactly the rationale of the aldosterone. And we find, of course, the production of aldosterone by the Zonula Glomerulosa in the cortex of the adrenal glands. Now, next up, we're going to find the Zonula Fasciculata. In fact, here we're going to find the glucocorticoids. This is, of course, we typically mean about the cortisol. Now, cortisol, in fact, has many functions, many biological effects in the human body. They can be easily revised and easily reviewed by simply overall saying that we have the catabolic and diabetogenic. Catabolic means that we have the effect of destruction of molecules, of the cleavage of molecules from complex to simple, for example, from polysaccharides to glucose and so on. This is the catabolic process as a conception. And the diabetogenic, of course, is the production of glucose in the blood. So when we talk about the catabolic and diabetogenic, we mean that we increase gluconeogenesis. This is the production of glucose from the human body. We increase proteolysis. This is the cleavage of proteins to produce amino acids. And as a consequence, this is again the catabolic. This is the very typical example of the catabolic procedure. Lipolysis, destruction of lipids, again similar. We decrease glucose utilization. This is because if we decrease utilization, we're going to increase the amount of glucose in the blood, hence the diabetogenic. Also, decrease insulin sensitivity. In short, the function of insulin is to uptake glucose from the blood to the cells, typically the muscles, for example. And of course, by decreasing the sensitivity, we increase the amount of glucose again that is in the blood. And now these next functions are going to be very important to you as a medical knowledge, that the cortisol in fact suppresses immune response. These are the typical immunomodulatory, physical, natural immunomodulatory products of the human body. Now, you're going to see, and you're going to use corticosteroids as treatments in many different cases of autoimmune disease or many different, let's say, aggressive, misfunctions and dysfunctions of the human body, of course, when it comes to the immune responses. And last, it's important to notice from this list that we enhance vascular responsiveness to catecholamines. Catecholamines, of course, means that we have the adrenaline, the epinephrine and norepinephrine. Of course, the adrenaline is exactly the same with the epinephrine. And this is pretty much what you should remember when you talk about the cortisol, the basics of cortisol in this case. And lastly, we're going to talk about the Zona Reticularis. This is the zone that produces by secondary function cortisol but mainly we produce weak androgens, the precursor specifically of testosterone. Now, in this case, it's important to notice that these androgens are present in both the female and the male or human body. And in fact, this is going to be where we're going to find the Zonula Reticularis. So we're going to always, this is always from the top to the center. So the highest, let's say, location from the cortex is going to be again the zonula glomerulosa. We're going to have the production of aldosterone, the mineral corticoid. Exactly, we're going to find this very typical presence of the cells. In this case, this specific hormone producing cells. Now again, we're going to find the concentric circles, let's call them in this way, tubular structures that in fact are the cells that produce the specifically in this case the aldosterone. We're going to easily distinguish the end of this layer, the first layer of the zonula glomerulosa, to the zonula fasciculata. This is again the location where we produce cortisol, and this is the one staining, and this is the second staining. These, of course, are taken again from the histologyguide.com. And again, we're going to find easily to distinguish the level of distinction between the two. The difference between the two sections is the intensity and the vividness of the staining. It's exactly, again, both of them are H and E, and they're actually very easy to distinguish when one stops and one ends. In the cases of weak stainings, you should actually try to locate the density of nuclei, one close to the other. In this case, we're going to find many nuclei right here, and lower we're going to see more sparsely located, so we can tell that approximately in this height is going to be the difference in the boundaries of one zonula to the other zonula. And exactly, if we keep on going deeper, we're going to find the next boundary, which is between the zonula fasciculata with the zonula reticularis. Again, this is very easy to distinguish the boundaries, and exactly again the same here. And again, the zonula reticularis is the one that produces mainly weak androgens, and secondarily the cortisol itself. Now let's talk about the medulla. If we keep on going deeper, we're going to find specific cells. In this case, are going to be called Chromafine cells. Now, why do we care about this so much? Because these are cells that are modified sympathetic neurons that in fact produce and secrete epinephrine or norepinephrine. We know the effects of epinephrine even by general knowledge. Of course, this is vasoconstriction, one of the most important ones. The second one is it increases the amount of glucose in the blood. Of course, this is again the molecule that is being produced in the fight or flight reaction. So this, of course, has to, as also a consequence of increasing the heart rate, increasing the blood glucose available in the blood, and of course increases you have vasoconstriction in order to increase the blood pressure as a consequence of the effect of the epinephrine and secondarily norepinephrine. So let's visualize them in the microscope, shall we? So again, this is the section. It's very easy to distinguish. So we have the capsule, again the cortex, exactly deeper than the medulla, and again the same from the other side. So if we zoom in, we should start identifying the different zonulas. So once we zoom in, we can actually see the different layers. The first one is zonula glomerulosa. We can again distinguish the two, the glomerulosa from the fasciculata, based on the density of the nuclei, and of course as a secondary feature the density of stainings, because this is not going to be always easy to identify and to see in the microscope. So based on the density of the cells right here and here, we can tell that this is the zonula glomerulosa exactly right here on this layer, on this exact definition and border. Straight beneath, we're going to find again the zonula fasciculata, based on the more foamy appearance and the more, let's say, less dense presence of nuclei. And exactly keeping on, we're going to start seeing the very easy distinction of the from the fasciculata to the reticularis. Again, this is the easy distinction based on colors mostly, and of course by the mostly by the intensity and vividness of colors. Again, this is the area of production of the weak androgens in this case. And by continuing, we're going to start seeing the medulla. This is very easy distinctions. It's very easy histologically to distinguish the layers. And lastly, here we're going to find the Chromafine cells along interspersed with the vessels, of course, with the capillaries in this case. And this intense basophilic structure will be in fact the Chromafine cells themselves. So they produce, of course, the epinephrine and norepinephrine in both cases. So let's move on. The point of understanding how these clinical features and clinical syndromes work is first understanding exactly what the specific hormone does. And if you understand what the hormone does, it's really easy to predict what is going to happen if this hormone is increased amount produced or decreased amount of production in both cases. For example, when we have the Cushing syndrome. Now, Cushing syndrome, of course, is the primary adrenal hyperplasia, and of course, this is the one of the most common things that we're going to find here is the increased amount of production of ACTH. And because we have the increased amount of ACTH, then again the diabetogenic and catabolic effects, we're gonna see exactly these catabolic effects and then diabetogenic effects to the maximum. Specifically, we're gonna find hyperglycemia. Why? Because again, cortisol induces an increased amount of glucose in the blood. Muscle wasting. Why? Because of course we have the catabolic effect, which is again the direct result of the proteolysis. Now, in fact, central obesity and round face are going to be again features that we're going to see in this Cushing syndrome. They're going to be easier to see, and this is the same logic. So if you understand how the cortisol works, how adrenaline works, how in this case the aldosterone works, how all of these hormones work, it's really easy to predict what is going to happen in the different syndromes. So this is again a classic picture of Cushing disease. Again, told you the hyperproduction of ACTH hormone. And again, we're going to see these typical features, the weight gain and the weak muscles because we have the increased proteolytic effect, and so on and so on.